Hello, we have to stick to the schedule. We have to start now.
Just to further on the last session, this session is also very important because this is related to communication and contraception. So without further ado, let's introduce our co-chair first, okay? So my co-chair is author and Belisa. It's a bit difficult for me to pronounce, so sorry for that. He's a gynecologist from the Nova Set, where I visited yesterday.
Really?
Yes, and he has a PhD in gynecology and psychology. His main interest is reproductive endocrinology.
Thank you. My co-chair is Simforosa Chan. She's from Hong Kong, WCPAG director, coordinator of the training center, and she was a host of this kind of congress 10 years ago.
Yes.
Should we start now?
Yes. So let us first introduce the first speaker. She is Elizabeth Ferrucci. She is a pediatrician and pediatric surgeon working in Switzerland. She is also currently served in the EuroPEP board. Elizabeth, please. Thank you.
So, good afternoon, everybody. I like starting my presentation thanking very much Professor Zoran Stankovic and Professor Paul Wood for inviting me to explore a topic which is basic in facing children and adolescents in PAG as well as in every other field of pediatrics. As told before, I am a pediatrician and doesn't work.
Yeah.
Okay. This is my disclosure as kindly requested by the organization of the Congress. As a pediatrician, dealing with the children and adolescents is my daily routine, and I might even say that a good interview is a centerpiece of our work, especially helpful in making a diagnosis. Of course, all of us physicians have our own mindset in taking a medical history. But in taking a pediatric history, there are some specific peculiarities that have to be considered. In pediatric, for example, we tend to highlight different things, and there are content differences for us. For example, it is especially significant, the prenatal and the birth history, such as the developmental history or the feeding history or the social history of the family, to highlight some kinds of environmental risk. And finally, the immunization history is crucial for us. In an adult, all this information is more often than not redundant. It is worth emphasizing that there is a heavy impact of the child age in obtaining an appropriate medical history. There are different ways to obtain an accurate medical history of a pediatric patient in different age groups. In general, patients are divided into 3 groups: patient younger than 1 year, between 1 year and 5 years, and older than 5 years. As evident, most frequently our history is not first-hand. And parents play the role of historians. They are interpreters between the history of a pediatric patient and us physicians. Under the age of 1, the patient is not involved at all in collecting the information, but later children are increasingly more and more engaged as their age grows to become progressively our elective interface. However, with parents, there may be some bias that may heavily influence our collection of data. Parents give their interpretation of signs and symptoms, but we do not know exactly their reliability. We do not know if we are interfacing with someone who under or overestimate signs and symptoms. And we have to pose right questions to get right and have full answers. We have to observe carefully the parent-child interaction and the quality of their relationship, as both may heavily interfere with our history taking. Parental behaviors and emotions are really very important, as well as it is important to intercept some kind of distress and sometimes even a sense of guilt, and it is important to adopt always non-judgmental and reassuring attitude. As told before, as children grow old to teenhood, autonomy in sustaining an interview grows, and questions can be asked directly. However, in general, in my experience, during the adolescence, all patients have the ability to report perfectly about the main symptoms and the history of a present illness. But on the other hand, adolescents may have difficulties in reporting about their past medical history, the pregnancy, the birth and development, as well as family history. This is the reason why, in principle, whenever possible and respecting the adolescent's privacy, the presence nearby of a reference adult is appropriate. Then, I would like to focus on a tool that over the past 30 years has radically changed the way in which psychosocial history is collected in adolescence. In 1988, Goldering and Cohen published an article entitled "Getting into Adolescent Heads," a curious and compelling play on words in which, besides the obvious meaning, heads also forms an acronym which becomes a path for a good interview in adolescence. More in detail, H stands for home and environment, for collecting data about family, home, and relationships. The first E stands for education and employment, to explore school results, behavior at school, relationships with peers and with teachers or with colleagues and employers. The second E stands for eating and exercise, and It helps to investigate about struggles, about eating or body image. This E was not present in the first publication, but in successive enhancements. Then we have the A, which stands for activities, for delving into extracurricular activities, hobbies and interests, and if necessary, even religion. The D stands for drugs and substances, and alcohol and smoking, which unfortunately may often be a sensitive issue in our teenagers. Other risky behaviors will be better explored later. Then the S stands for sexuality. This is one of the most important topics, maybe one of the key issues in PAG. And with it, we explore contraception and sexually transmitted diseases, and eventually even diseases with sexual orientation and with gender identity. Over the time, HEDS has become HEDS. In fact, besides the second E already explained, two more paragraphs were added in time. The S of suicide and depression, very basic item in psychosocial history, exploring in deep emotional aspects, and the S of safety, to deepen the perception of risk, hazardous behavior, and risky environment. So, these are some indications for a theoretically effective pediatric anamnesis. But in practical experience, there are many, many factors that can interfere with our task. In infancy, in fact, our children themselves may boycott our work. In general, neonates and young newborns may be somehow bribed with a full tummy. Later on, and up to 4 or 5 years of age, the biggest problem is that we are in competition with the children for the parental attention. And our young patients may accept with difficulty that parents may be focused on us and not on them. In these cases, it is helpful letting children actively participate to the conversation and creating ways to entertain them with picture books or drawing tools. Anyway, our clinics should always be child-friendly. As told above, as children grow older, their role becomes more and more active. That is when patient-centered communication skills become an essential tool for us. It is crucial not to focus our attention only on the medical aspects, but to consider the patient as a whole, to know how to elicit trust with honesty, with respect, and with acceptance. Finding points of contact and presenting ourselves in step with times, showing our knowledge of current issues can be, however, a point of contact and can facilitate us in stimulating teenagers to open up, to be honest and not omissive. At the end of my consideration, I would like to point out one aspect that I think is basic in interacting with children and teens, namely body language and tone of voice, which should never be imposing, never assertive, and never appear hasty. Never should we bring out a position of dominance and superiority. This theme is also applies in reverse. Knowing how to read an elusive eye contact, a subdued tone of voice, monosyllabic answers in teenagers should help our efforts to improve our communication with them. I apologize for my ultra-concise communication, but time is short and I must close. I am available for questions, and you can reach me to my email address. Thank you very much.
Please take a seat first. We will take the question at the end if we have time.
Okay, thank you, Dr. Ferrucci. Our next speaker is Chandra Moli, a distinguished scientist. She comes from the Department of Sexual and Reproductive Health and Research, World Health Organization, and joined a program with the World Bank Human Reproductive Program. Please, Chandra Moli, the floor is yours.
Namaste and greetings from the World Health Organization. I lead WHO's work on adolescent sexual and reproductive health and rights. And in this presentation, I'm going to talk to you about WHO's approach to adolescent, improving access to and uptake of contraception by adolescents. I'll begin with some trends. Globally, over the last 25 years, the adolescent birth rate has declined from 60 births per 1,000 girls aged 15 to 19 to 44. Although, as you can see on this slide, progress has been slow and uneven in different parts of the world. Globally, levels of child marriage, which is hugely associated with early childbearing, has also declined. We used to say that 1 in 3 girls were married before the age of 18. It's now 1 in 4 girls. Rates are falling, and again, as you can see, the rates are different in different parts of the world. Trends in the uptake of modern contraceptive use by adolescents. This paper, published in The Lancet, compares trends in contraceptive uptake in a number of countries listed on the bottom of this slide. And here again, you see that there is progress, although, of course, we would love to see the progress to be much faster. And the last slide, which talks about trends, is the percentage of girls whose demand for family planning has been satisfied. This has increased over this time period from 36% to 60%. So 6 in 10 girls have their demand for family planning satisfied. That means 4 in 10 girls do not. And as shown in this slide, progress is uneven. I want to talk a little bit about, we've talked about progress, but we have to talk about who's being left behind. The previous speaker in the HPV vaccine session talked about that. I'm going to give you a study from India, a large study, 10,000 girls in 2 states, Uttar Pradesh and Bihar. They surveyed young adolescents as well as older adolescents. None of these girls wanted to get married early. None of them wanted to become mothers by the age of 18. 75% of them in Bihar were married by 18, 40% of them were mothers by that age. Within marriage, they experienced violence, and whatever autonomy they had of movement decreased. And they couldn't do what they wanted to do because of economic constraints and social chains. Now, of course, you might think that's true for India and true for Bolivia, but it's true for Western Europe. This is data from Scotland. Scotland has published a teenage pregnancy strategy, and one of the most important findings that informed the strategy is that females aged 20 and under living in a deprived area were 4.6 times more likely to experience a pregnancy and 12 times more likely to continue with the pregnancy. So this is not a problem of Bolivia and Colombia and India. This is here. And I live in Switzerland. I've lived in Switzerland for the last 30 years, even in one of the richest countries of the world, which had one of the best COVID strategies, nobody fighting with anyone. There are pockets of poverty and deprivation. So there's a big slogan in the family planning field and in the reproductive health field, she decides. That's our goal. But the reality is substantial numbers of girls and young women don't decide. It's their mothers-in-law who decide about contraception. It's their partners who will decide about contraception. So we need a public health approach to dealing with this. And we have a 5-pronged approach in WHO, grounded in a wonderful framework by the International Center for Research on Women. It starts with the girl or the young woman and her partner, looking at demand, and then it looks at supply. I must say I was a little uncomfortable with that entire focus on the doctor educating the mother or the father and the adolescent. Where is school-based sexuality education in this? You know, we can't entirely base a strategy on specialists. Demand and agency. The story of Aditi. Aditi is 16 years old, fictional figure. 6 months ago, her family married her to Sahil, a 21-year-old man who works with his father to run a small workshop. Aditi lives with Sahil and his parents and 2 younger siblings of Sahil. Every evening as they prepare the evening meal for the family, Sahil's mother says, "Oh, I'm dying for a grandchild. I'm dying for the pitter-patter of little feet." There's huge pressure on Aditi to become a mother. And in this situation, when a girl or a young woman is under pressure to become a mother, within or outside marriage, I lived in Zambia for 10 years before I joined WHO, there's huge pressure on girls to prove fertility before you can get married. And so, if there is such high pressure to produce a child, you can throw the contraception outside the window. It's of no use. The story of Maha. Maha is 15 years old. She's from Egypt. She studies in an all-girls school. She's embarrassed by all the changes taking place in her body and confused by the feelings she's having. She tried to speak to her mother without success. There's no sexuality education in her school, apart from a basic discussion on your uterus and fallopian tubes and things like that. But Maha has learned many things from the whispered conversations in the playground like I did. You know, I learned about sex in the school playground, from a friend. The problem is that's true in Western Europe. I don't know whether you've been following the news about what's happening in England. It's a small group of parents, largely influenced by what has been learned in the US, criticizing England's sexuality and relationship education, and publishing articles in the Telegraph, in the Daily Mail, huge backlash. And I really hope we can talk about that in this meeting, because you are the champions who need to make it happen. Barriers to sexuality education are not in Egypt or Colombia. It's here, among the richest countries in Western Europe. Story of Julie. I'm not going to read the story. I'm going to let you read it. These are interesting little stories that we wrote with these young women. Julie is 17 years old. She lives in Masaka in Uganda. She's thinking about using contraception, but there are lots of misconceptions among her friends. just like there are lots of misconceptions about HPV. And unless we deal with this at a young age with good quality sexuality education, like the great programs in Argentina, the great programs in Uruguay. Can I have a hand up from the Argentina group? Talk to them about their program. Argentina is crumbling economically, but their sexuality education program is still growing strong. That's what you need. The second point, lack of desire to use contraception is because fear of side effects, fear that contraception can prevent a return to fertility. And these are things you need to talk. It's not about telling, it's about engaging, it's about understanding, it's about working with them. And we desperately need that. The story of Claudia. Claudia is a factory worker in Guadalajara in Mexico. She and her boyfriend Osvaldo live in a little apartment at the edge of town. Claudia works in a factory making children's clothes. She sends a part of her earnings to her parents who live in a village in the south of Mexico. Claudia doesn't want to have a baby. She's tried talking to Osvaldo about it, but he dismisses it every time. Now, this is a big problem. When young people are reluctant to talk, say that they are sexually active. Now, I had sex before I was married. I had to go far away from home to a pharmacy where I knew my mother would never go to ask for condoms. And I waited till everyone left, and then I went in and got the condom. Sometimes I got the condoms, walked out feeling like a king. Sometimes I was scolded and thrown out, and I can still feel how my ears used to burn with shame. So that's the reality for many adolescents even today. And that's the reality. Not able to talk about that you're sexually active, embarrassed to talk to your partner, dismissed by your partner, and then dismissed by your mother-in-law or sister-in-law, who decides? So we have to deal with that before we can talk about providing contraceptives. And that is important too. Take the story of Galina from Chisinau, Moldova, a country that I work with very closely. She lives in Chisinau, and this story is about a young couple who get carried away and looking for emergency contraception. It's available in the pharmacy, but it costs an arm and a leg. And the government clinics are closed. And that's true for so many parts of the world. In so many countries, even where family planning programs are in place, emergency contraception is not available. HPV vaccine has to come, but we have to start with basics, and we must have contraception for everyone. Limited access to contraception because of laws and policies, because of adolescents are unaware where to go, unable to pay for it, lots of barriers to be overcome. We had a wonderful presentation by this lady from the Philippines. Wonderful presentation. I love your presentation. But Philippines passed a reproductive health law, a great law, but many of the provisions for adolescents were watered down. So we need access to contraception, government-led programs in all countries of the world, including mine in India, where girls in Bangalore, where my mother lives, were asked to, they did a surprise check on the girls, and when they found some condoms, they suspended the girls and called their parents for a disciplinary discussion. That's the reality that we are working with in so many places. So what do we need to do differently? We need to move from a one-size-fits-all approach to an approach tailored to the different needs of different groups of adolescents. Adolescents, we talk about it as one group, but a girl of 13 is very different from a girl of 18. So many differences. Secondly, we must move from separate centers. All over the world, sadly, there are separate adolescent clinics. Many of them are empty, whereas antenatal clinics and postnatal clinics and HIV clinics are bursting in their seams with young people. And so we need to work and integrate contraception. England's pregnancy contraceptive promotion program was an excellent one. It was a whole campaign about the time to think about avoiding your next pregnancy is now when you're pregnant. So they showed this campaign with a pregnant woman. That's the kind of programs you need to integrate them. Pharmacies. Now we talk about pharmacies, and I told you I went and got it from a pharmacy. Pharmacies are a great place to go because you can go and get the stuff. This is a paper from Ethiopia, a paper from Nepal. Nepal is very interesting. 4 girls go together to the pharmacy. They know exactly how much the emergency contraception costs. They tell the man, give me emergency contraception. And if he says, who is it for? That's none of your business. Can you give it to us? You don't want to give it? We'll go somewhere else. He loses money. So he gives it to them. So it's anonymity. But remember, pharmacies do not reach everyone. This paper by my colleague Asante Kamuyango said poor girls from poor families and rural areas don't necessarily have access to pharmacies. So pharmacies are good, but they're not a panacea. They're for the wealthy, they're for us, but they're not for everyone. And I'm going to end with some soul searching. This is the story of Ronald. You're a medical officer in charge of a busy municipal clinic. In addition to your clinical work, you're responsible for the overall management of the facility. Young man of 18 bursts into your room, slams the door and walks to you. He says he's very angry, he's trembling. He says, when I talked to you last week, you told me no one would come to know. Yesterday, my mother said one of the nurses told her, I will never trust you people again. Poor quality is a big issue. Disrespect and ill treatment of adolescents. And I don't know whether you're going to talk about this, but we in WHO are working in ill treatment of women at the time of childbirth. Do you know that in some countries, 1 in 2 women are beaten or slapped at the time they're giving birth? By doctors, by nurses, by midwives, by people like us. I hope we can talk about uncomfortable things like that. So in that context, we talk about disrespect, but it's also lack of knowledge. Many health workers will tell an adolescent, why do you want to talk about contraception? Now use condoms if you want, otherwise you come back after the first baby. Or in Asia, where I'm from, come back after you have a male baby, because nothing else is more important than a male baby. And we think that the only solution to poor provision is training. They say that if the only tool in your toolkit is a hammer, everything looks like a nail. If there's a problem with patient flow training, if there's a problem with attitudes training, if there's a problem of competencies training, increasingly what we are saying in WHO is let's stop spending 80% of our public health program budgets in training. There are other evidence-based approaches to improve competence, which includes some of the items listed on this slide. I'm happy to talk to you about that. One of the most important approaches, what we found, is bringing trained health workers together to talk to each other and support each other, collaborative learning. They learn much more from peers than from experts who come in and tell them what to do. They learn from each other about, if, for example, the adolescent girl doesn't want to talk, the mother's sitting in the room, you want to tell the mother to go out, and the mother says, who are you to ask me to go out? I'm paying the bill, I will sit here. How do you deal with that? No WHO expert is going to tell you that. Another health worker around you is going to tell you that. And lastly, we need to get adolescents involved in accountability programs so that adolescents can contribute to giving feedback as to how they were treated. Because it's very easy for health workers to give you, to say that they did something. Give you a study. World Bank published a study of huge numbers of health workers in India and in China. They scored very well in the presence of evaluators. 1 week later, they sent dummy patients and their scores fell from 80 to 20. They knew exactly what to do, but they didn't do it. How many more minutes do I have?
8 minutes.
Okay, great. So I'm going to take a few more minutes to go to the clinical perspective. I've talked to you about the public health perspective. And the public health perspective is crucial to thinking through this and to think about demand, to think about supply, and to go away from the paradigms and to think about the fact that we have done this all is not true. Okay, 5 points here. First is what I said is we need to think about adolescents as a homogeneous group. I think the first speaker or the second speaker talked about screening and being aware that there may be violence. The head's approach is another wonderful way of doing that. Some adolescents may not be sexually active. Others might be. They may be in a consensual relationship or they may be coerced. And they have changing needs, which we need to understand. So the same Sylvie or the Gloria whom you met last week may not be the same Sylvie or the Gloria this week. In my work in Zambia, half the time of my patients would be, they would start with, I have a headache, doc. I'm so tired. And only after 3 minutes, they'll say, "Doc, that's not why I came." They're trying to suss you out and see whether he's worth talking to. Secondly, we must move from a condoms and pills only approach to an approach that provides a full range of methods, including intrauterine devices, including hormonal contraceptives, and not take efficacy as the only consideration, but to think about other things, including circumstances. You know, many adolescents may not be able to keep the pill at home because they may be unmarried and may be having sex without wanting their parents to know. The third one is we must move from a mindset that sees contraceptive information and counseling as someone else's task. You know, my job as a doctor is to prescribe, and then you can go and get that information from somewhere else. Increasingly, what we see is communication with a health worker to address these issues, work with people, work with norms are the crucial issue. During the COVID pandemic, what we advised countries was, even if a young woman is coming with another female relative to your clinic, talk to her alone, because you may not know whether that your client or patient has talked to the other person that she's using contraceptives. We must move away from urging contraceptive use to prevent unintended pregnancies. This is one of our big learnings. And this is what we have learned from Alison Hadley with the teenage pregnancy strategy in England and many other countries. You place contraceptives as a means to attain the life goals of taking charge of your life, of moving ahead, and it's not the end in itself. You know, it's about who are you? Where do you want to be? Where do you want to go? And then lastly, a wonderful study that we carried out with colleague Sylvia and others from Argentina, which says, once you give a long-acting method, how can you prevent discontinuation? With counseling, with empathy, understanding what their problems are, finding out what they need, switching methods if you need to, so that you can continue. You know, again, a powerful program, nationwide program. To conclude, 2 messages. One is, from 40 years of experience, and we had a wonderful initial presentation on brain development. And what brain development in adolescents, what it tells us, cognitive development, brain formation is, adolescents by 15 know much more than adults, in fact, more than adults. It's not a problem of lack of knowledge. It's about managing impulse control. It's about knowing, you know, where you can stop if you need to. So telling adolescents what to do doesn't work. We must protect adolescents. Yes, I have a daughter with epilepsy. I want to protect her as much as I can. But in Switzerland, she's encouraged to take public transport. She's encouraged, if she has a convulsion, to sit down and ask for help, get on with her life and move on with her life. So I want to protect, we want to protect, but we really need to protect them by giving them information so that they can take charge of their lives. That's why I'm so uncomfortable with an approach to HPV vaccination promotion that is reliant entirely on a specialist. It should be the adolescent girl who takes charge. It should be the adolescent boy who takes charge. We must prepare them and support them in making their decisions. Mike Ryan, whom you may have seen on TV, a roly-poly Irish guy who leads our COVID work, you know, wonderful guy. You know, there was a lot of blaming of young people during the COVID pandemic. And, you know, he says this, we need to have a conversation and young people need to lead that conversation. The last thing a young person needs is an older person pontificating and wagging their finger. It never worked with him. He's talking about himself. We need to find a better way to engage young people. We need to give voice, responsibility, empower, and resource them to do this. So let me conclude here by saying that we have a tool, contraception. Contraceptive uptake is increasing, but we need to do much more to reach the girls and young women, the boys and young men who are not being reached. As gynecologists, much of your focus is on girls and women, but I don't know whether you're aware of the literature on boys. Boys everywhere are in crisis. All over the world, apart from the elite boys, boys are losing their place in education, losing their place in the family, losing their place in employment. Boys need help not only for themselves, but also for girls and women. We need to think about working with boys. And we need to think about finding new ways to change the way we improve health workers' performance to deliver on the things that they do with the full involvement of young people. Namaste and thank you.
Thank you for this fantastic lecture. Next, we are going to move to talk on the contraceptive options for adolescents with chronic illness, which will be delivered by Marisa. She's a gynecologist from Argentina and the current member of the Fiji Executive Board.
Thank you. Thank you, everybody. It's so difficult for me to talk after this conference. I'm so sorry. And yes, can I see the... Thank you very much. Well, first of all, I want to thank you, Soran, for this great Congress and for inviting us. And thank Silvia for her important work in Argentina the last years. Well, I have 15 minutes to talk about a big issue. I try to resume. I have no conflict of interest. What is already known on this subject? Well, approximately 30% of adolescents suffer from one or more chronic conditions. Chronic conditions are direct and indirect causes of maternal mortality. Contraception may play an integral role in reducing the risk of dying in chronically ill women. However, the use of contraception in this group is often suboptimal. Adolescents, including those with chronic conditions, are sexual beings. Decisions on appropriate contraception must be based upon informed choice after adequate sexual health education. Chronic illness may confer additional risks to an adolescent should she become pregnant, and some medications used to treat these illnesses are teratogenic. Pebbles is an adolescent with a chronic illness who has sexual and reproductive rights. We need to work for her to have an enjoyable life. I tried this trial because I think it's very important. Adolescents with chronic illness have sexual interests similar to those of their healthy peers, and they receive a lot of attention about their illness, but very little attention about their reproductive health. In this trial, they ask pediatricians about how they investigate about sexuality life, sexuality, contraception, STI, or if they inform their patients about the teratogenicity of the drugs, or if they have an illness that contraindicate pregnancy. And the conclusion of this trial is, despite frequent contact with the medical field and use of teratogenic medications, medically complex adolescent girls are inconsistently screened for sexual activity and rarely referred to gynecologists. And as we know, we need to work multi-interdisciplinary. What do we need to know before prescribing contraception? Well, we need to know all of these: type of chronic disease, drug teratogenicity, contraindications, desire for pregnancy, absolute pregnancy contraindications. First of all, we must know if the pathology presented by the patient has an estrogen contraindication. Secondly, it is essential to understand if any way of administration is contraindicated. Thirdly, if the pathology affects the effectiveness of the drugs. And lastly, if the pathology contraindicates pregnancy. For example, some HIV antiretroviral agents reduce oral contraceptive efficacy. And for example, severe congenital heart disease absolute contraindicate pregnancy. We need to know, as said before my talk, Dr. Chandler, sexual rights and reproductive rights are human rights. And we need to provide a comprehensive reproductive health education, full access to a range of contraceptive methods. We need to allow affordable health benefits, allow ability to make decisions freely, and avoid, obviously, violence. And we need to found a relationship with privacy, confidentiality, non-discrimination, respect, empathy, and trust. And we need to know that the age alone does not constitute a medical reason for denying any contraceptive method. We need to talk about the conditions. And as you know, for counseling, we have 3 steps. We base on the eligibility criteria. You can choose WHO, CDC, UK, Argentine, or any country. But we need the 3 important steps. The first one is to listen the needs of the patient. We need to listen what she wants. If she wants to avoid pregnancy, if she wants to avoid her mother knows about the contraceptive method, we need to know everything. And the conditions, in this case, if she has an illness. Then we have the knowledge. We need to explain to the patient which one are the best option for her condition and for her needs. And in the third step, we need to explain what it is expected to happen in order to continue using the method. We need to explain everything, what will happen with her with the method. General evaluation does not differ from healthy adolescents. We need to obtain a sexual history, a history of sexual transmitted infections, and obviously obtain medical history with particular attention to chronic illness in our cases. I tried this guideline because I think it's useful. Here in this guideline, you have the chronic illness. Then you have if they can use combined oral contraception and or POP or progestin-only contraception, and which one is the first option for any of these conditions. For me, it's impossible to talk about all of the conditions. I choose only one and how to manage these situations. We need to know that, in general, progestin-only methods have only one contraindication, only for class, that is current breast cancer. And it's very uncommon in our patients, in adolescent patients. And in general, you can choose a progestin-only method without any complication, because the other things are class 3, the risks outweigh the benefits, but you can choose this one if the patient accepts this. And in general, they are hepatic complications. And obviously, LARCs. LARCs are the best option for these patients. In general, IUDs has only local contraindications, and in general, the only one, as I said before, is actual breast cancer. All of the organizations around the world and the societies recommend the use of LARCs for this kind of patients because has the less contraindications. And well, my patient is Pebbles. She's dating Bam Bam, and they need contraception. Pebbles is 18 years old. She lives with her parents. She has had ulcerative colitis since she was 15 years old. She takes Pentasa daily and has not had any crisis for 6 months. Men are 12 years old, menstrual rhythm for 4 days each 30 days. First sexual intercourse, 17 years old. She used condom, she has no pregnancies, but they wish to add another contraceptive method. Nothing important in her family. And well, I choose here the CDC criteria and UK criteria in order to show you how to manage. And well, we can see here that she has no contraindications of any methods because she's okay with her illness. And in UK criteria is the same. She has no contraindications for any methods. And UK recommend that women can be informed that a causal association between combined oral contraceptive use and onset of exacerbation of IBD has not been established. But in general, she can choose any of the methods. And in these practice guidelines, we can see here that for combined oral contraception, we can use and should avoid this contraceptive only with active or extensive disease, recent surgery, volume depletion, corticosteroid use, vitamin deficiency. And in general, they said that IUDs should be the first line choice. DMPA is not recommended because of osteoporosis and because this patient has problems with the absorption, and they use corticoid for a long time, and it's not the best option. And if the girl decided for IUD, as I said before, is the best option. We listen to her is the most important thing. First of all, listen her with empathy and with trust and private. And she's afraid to take pills daily. The options patch, ring, implant, IUDs, but she does not feel comfortable with vaginal contraceptive. She doesn't like IUDs. She prefers an implant. It is necessary to talk about bleeding patterns and possible situations. This is very important in the counseling to explain the patient what happened after she begin with the method. The bleeding patterns with implants are very important to be explained. Obviously, double Dutch. Condom not only protects against pregnancy, but also prevents STIs. And emergency contraception is allowed and has no contraindications in any of these chronic diseases. And finally, in conclusion, contraceptive counseling is an opportunity to promote a healthy and sexual safe life. Information about body function, reproduction, sex, and contraception are among the most basic needs for adolescents. Healthcare providers must know the best contraceptive option and potential contraindications for patients with chronic illness. Detailed counseling and anticipatory guidance about bleeding expectation is essential to improve continuation. Dual method use should always be recommended. After a contraceptive method is selected, attention should then be directed to ensure correct method use, continued use, and reliable follow-up care. Thank you for your attention and support.